Today we're talking about HIV-associated opportunistic infections. And I mean, you guys have been hearing about opportunistic infections probably since you were in medical school. I know you have since medical school because I'm lecturing the medical students on the same topic next week. So for this lecture, we're going with more of a case-based approach. It's very similar in some of the cases, maybe similar to what we did in the spring for our second year fellows. My goodness, all these people admit. Okay. So you guys, I'm sure, have all seen this curve. The blue lines are CD4 count over time in HIV, and the red line is sort of the risk, it's the viral load. And over time, especially years into having HIV, as the CD4 count drops, especially dropping below 200, is when we really start to see all those opportunistic infections and eventually death. And as you guys know from being here at Tampa General, we have a few of these patients who fall into this category admitted right now. These are generally people who many times or most times probably are not in care. Sometimes it's people with undiagnosed HIV. And our patients who take their antiretroviral therapies, they tend to not progress into this category. And so this data is a little bit old, but it's sort of hard to find the brand new data. But this graph shows how common AIDS-defining opportunistic infections were in the US and Canada from 2000 to 2010. During this time, we really saw a big broadening of antiretroviral therapy. It was available to more people, more tolerable, more effective. So over this 10-year period, we saw a decline in infections. But what I like this graph for is also it sort of highlights which ones are the ones that we're most commonly going to see. For many presentations in people with HIV, the differential is broad, but it also helps to keep in mind the things that we see more commonly in HIV and that we have to think of. So PJP is the most common opportunistic infection, right up there with esophageal candidiasis. And then there's a falling off, but then we have MAC, tuberculosis, less so here, but we do see it. Cryptococcal meningitis, toxo, CMV retinitis, and PML are on this chart. Okay, so this is just a teaser question. We did this one last time we did this lecture, so could someone read this? Sorry, I can't see who's on the call while I'm presenting.
Yeah, I can read it.
Thanks.
For which of the following infections would lifelong suppressive therapy be indicated for a patient with a CD4 count of less than 50 and high viral load, regardless of subsequent success of ART regimen in terms of CD4 count and viral load? Disseminated histo, crypto, cocci, miliary TB, or disseminated MAC?
Does anyone have a guess for which one would require lifelong suppressive therapy?
Disseminated MAC?
Coccidioidomycosis.
Yeah, the
I'm gonna go with
Yeah. Yeah, so cocci meningitis will actually require lifelong suppressive therapy. And this is more of a question to get us thinking about the different sort of stages of treatment in people with HIV. First, we have preventing of infections, primary prophylaxis, or in this case, it would be secondary prophylaxis, or and then we also have treatment when we have a diagnosed infection. So often these are things you may look up in your patients, especially for something we don't see a lot like cocci. But as a review, primary prophylaxis is to prevent the initial infection, and there's only a couple indications for people with HIV. We'll review those. And then secondary prophylaxis can prevent recurrent infections. And many opportunistic infections require secondary prophylaxis. And usually until your CD4 count recovers. In some cases, it's even longer. So we're going to start with someone who comes in with cough and shortness of breath. Would one of you be able to read this case?
John is a 35. Oh. You want to mute them? I think there's an echo.
Yeah, there's definitely an echo.
I can read this one. John is a 35-year-old man, newly diagnosed with HIV. His viral load is 350K. CD4 is 10, and is seeing you to start ART today. In addition to starting ART today, what primary prophylaxis should be initiated? No prophylaxis, as he's starting ART. Trimsulf 1 double strength daily, Trimsulf 1 single strength 3 times weekly, TIW, and azithromycin weekly. Dapsone, azithromycin weekly.
What's the answer to this one?
B.
B. Okay. Does anyone want to give him a Zithro as well? Good. Okay. So yes, trimethoprim sulfa 1 double strength daily. For PJP prophylaxis, this is going to be the most common thing we're prophylaxing people against. Anyone with a CD4 count below 200. The preferred are either 1 double strength or 1 single strength tab daily. There are alternative regimens as listed below there. While we didn't have it on the slide here, in people with HIV who are starting antiretroviral therapy, we no longer prophylax for MAC infection with azithromycin. Technically, if people are not on ART, you should be prophylaxing for that if the CD4 count's less than 50. But generally, we want people on ART. Fernando, you want to read this case?
Sure. John had difficulty obtaining his ART and prophylaxis from the pharmacy and was lost to care. 6 months later, he reports to the hospital with over a month of progressive shortness of breath with a dry cough and fever. Chest X-ray and CT are shown. Exam is hypoxic to 85 in room air, diffuse crackles bilaterally, and PaO2 is 60.
Okay. Which test is most likely to confirm your suspected diagnosis?
Bronchoscopy.
Always the answer, right? try to get a bronch. Oh yeah, and I think you, John, what are you treating or diagnosing?
Pneumocystis.
Yeah, right. Yeah, this is a typical presentation of pneumocystis in that it's someone with a CD4 count generally below 200, not on antiretrovirals, not taking prophylaxis, and in people with HIV, it typically presents as this subacute progressive dyspnea that's can sometimes sort of sneak up on people over time. The pulmonary exam may or may not be impressive, but the hypoxia, especially if you get an ambulatory O2 set, is often impressive. And our typical workup is chest X-ray, CT chest, and then as you guys got, if you're trying to make a diagnosis from sputum, a sample from a bronch with BAL will be more likely to prove the diagnosis than an induced sputum, and that's more likely than just an expectorated sputum, though as we previously discussed, we've certainly seen patients who you can see PJP even in the expectorated sputum. Okay, and then sometimes we can send serum markers, LDH, beta D-glucan, are sometimes sent. Ideally, it's best if we can just get a sample from the lungs. Okay, so you send the appropriate diagnostic evaluation. What do you recommend for treatment while you're waiting for your results to come back?
E.
E. And why are you including the prednisone there, Lauren?
Because of his hypoxia and level.
Yeah. Yeah. So for severe pneumocystis pneumonia, the treatment is trimethoprim sulfa at somewhat high doses, and then steroids. And there is a mortality benefit with early steroid initiation, and we'll look at that figure in a second. This is the PJP treatment official recommendations. On the left is mild to moderate PJP, on the right is moderate to severe. The main difference is that the guidelines recommend starting with IV in people with moderate to severe rather than the option for PO. And then you certainly add adjunctive steroids for hypoxia as shown there. And this is an old paper, but one that sort of showed the benefit of steroids early on. And so when you look at this figure, I know these old graphs are not colored, but you can see that the lines with the X are people who, the mortality rate for people who were treated with standard treatment and the risk of death. Sorry, this one's death. And these other ones with the circles are people who were given steroids. And you can see that there's a pretty dramatic reduction in mortality over here on this one and of severe disease in people who were treated with steroids along with antibiotics for pneumocystis pneumonia. And these were in people with hypoxia. And so that's why that's a very strong recommendation and something we're always doing when we know or suspect severe PJP. Okay, this one's a little random. Can someone read this one?
BAL returns positive for PJP by immunofluorescence. Cytology reports several inclusion bodies in the BAL. The critical care team calls you overnight to request the addition of IV ganciclovir. Best course of action is
Okay. And Celia, have you ever had this? Yeah. And why do you say that?
who said yeah?
Or who said yeah?
Oh, sorry. I said E.
Thank you. And why do you say that one?
I mean, rarely for HIV do you get CMV pneumonitis presentation, and clearly we're treating the PJP, and so
Yeah. Yeah. And so this, you know, we get this when people get bronchs, as you guys I'm sure have all seen. A whole lot of tests are often sent, including panels that may detect things that may or may not be clinically significant. And so we have to look at the clinical picture and decide whether or not we really think CMV pneumonitis is contributing to this, or whether it's, you know, the PJP pneumonia, which is much more clinically appropriate. And for HIV pulmonary disease, as we mentioned earlier, for all presenting symptoms pretty much in people with HIV, there's a wide differential. And some of them include things that are more common for people with HIV or less common. And some of them are common infections in all people, but they're worse in HIV. And some are more specific to HIV, like the pneumocystis. Things that rarely affect the lungs, but can affect other things in HIV and cause severe disease elsewhere are CMV, MAC, HSV. And then, of course, if someone has respiratory concerns, you always want to evaluate for non-infectious causes and other typical infections. Okay, so if John's getting better on treatment for PJP, when should John start ART? Would any, yeah, John.
B as in boy.
Sorry, what'd you guys say?
B as in boy.
B as in boy. Yeah, that's the correct answer. The correct answer is that for someone with PJP, you should start antiretroviral therapy within 2 weeks of starting PJP treatment. You don't necessarily need to start it the day they're walking in the door. Ideally, we would not wait until after discharge and make sure they follow up at the health department prior to starting it, though sometimes circumstances lead to that. And this is one of a variety of papers that looked at when ART is started in comparison to the diagnosis of an opportunistic infection and what the outcomes are. And it's not like, you know, rocket science. I think you guys might expect this, but people were either, they either looked at people who got early treatment of HIV after diagnosis of an opportunistic infection, that meant within 2 weeks of diagnosis of that OI, or they got deferred treatment. So sometime after treating the OI, they would then start ART. And people did much better in terms of this outcome is time to death or a new AIDS defining illness if ART was started within 2 weeks. So there are a variety of other studies that sort of show similar results. For many, though not all OIs, we ideally would start ART within 2 weeks after diagnosis. Who would like to read this one?
John completes the course of treatment for PJP pneumonia and starts ART prior to discharge. He developed a rash near the end of his TMP-SMX course, so he is started on dapsone prophylaxis instead. 10 days later, patient returns with headache, shortness of breath. CT chest is normal, pulse ox 85, on room air, ABG, pH 7.4, PO2 96, O2 sat 96%, 25% methemoglobinemia. Which of the following is the most likely cause of the patient's syndrome?
D.
D. Dapsone. That is correct. Dapsone can cause methemoglobinemia. We had a patient around Christmas time, I think it was, or somewhere in there. I don't remember, Dr. Montero, who came back in with this and had, pretty much this exact case presentation. So it's a real side effect and something to be aware of and to look out for. Again, just remembering that, like, not every shortness of breath that people come in with is an infection. Okay, so now moving on to headache. Celia, you want to read this one? Or somebody
George
else?
is a no. I'm here. George is a 28-year-old man with HIV, non-RT. Most recent CD4 count was 18. Viral load 500,000. He presents to ED for a severe headache and fever for about 2 weeks. He denies neck stiffness. On exam, he notices a few small umbilicated papules scattered on his arms and legs, similar to the image shown. Which of the following be most helpful in obtaining a diagnosis? Blood cultures, CD head, MRI brain, or LP? I want to say LP.
And what are you looking for, Celia?
Cryptococcus. High opening
Yeah.
pressure in the Cryptococcus.
Yeah, I think your team has one of these right now, right?
Yes. Well, in the blood, but we'll see if it pops up in the
Right.
CSF, and most likely the CSF, yeah.
Okay. So this one I think is helpful. These slides or some of these images are from the National HIV curriculum that I always tell you guys I love so much because it's so easy to read. But they show some of these figures to just talk about how common are different symptoms at the time someone's diagnosed with cryptococcal meningitis. So you can see that most people have a fever, 2/3 have a headache, only 37% reported a stiff neck, and then smaller numbers with changes in mental status or cranial nerve deficits. But I think this is sometimes helpful because sometimes you're like, oh, it's a headache. They don't necessarily need to have a stiff neck at the time you first see them for you to be suspicious for cryptococcal meningitis if the situation is correct. Headaches and HIV obviously have many other causes from other infections, especially like neurosyphilis, other CNS infections, other opportunistic infections. I mentioned a few of them here. And then medication. Some of our antiretroviral therapy regimens can cause mild headaches as a side effect, especially our integrase inhibitors. It's the most sensitive test for diagnosing HIV-associated cryptococcal meningitis. You guys going to do a serum PCR test?
I don't know if it's a PCR antigen testing.
From which site?
From CSF, I would think CSF.
Okay. Yeah, so we look for the crypto antigen. It often can be positive in serum, but we definitely always check for it in CSF too if we're getting the lumbar puncture. And it's highly sensitive in both serum and CSF. If you're getting a lumbar puncture, what you typically see on the CSF profile would be a lymphocytic pleocytosis, and the elevating opening pressure is what we're always looking at, as Celia mentioned. CSF PCR is not something we routinely use alone. If you're really suspicious, you probably also want to get the antigen because it can be included in those panels that we see, but the antigen is preferred. And you certainly can see the blood culture positive in many people, like Celia's patient who appears to have cryptococcosis, maybe with or without a meningitis. I don't know the details. So an LP is performed and his lumbar puncture looks sort of as you expect. The opening pressure was 30. The white count is 22 with 80% lymphocytes. The cryptococcal antigen is positive and the culture grows cryptoneoformans. And one of our first year fellows, any of you aware of what the preferred treatment is for cryptococcal meningitis?
Yeah, and induction therapy with amphotericin and cytosine.
And what about the steroids, plus or minus steroids?
As far as I know, steroids are not used.
Yeah. Great. You got it right. So cryptococcal meningitis is, a really common cause of death for people living with HIV worldwide. And it's better studied than many of our opportunistic infections. And so I'm going to show you some of the major trials, the key findings of some of the major trials related to cryptococcal management. I'm not going to ask you this, but the main toxicity associated with flucytosine that you'll be monitoring for is leukopenia and thrombocytopenia. As you mentioned, induction therapy is how we treat cryptococcal meningitis with liposomal amphotericin B and flucytosine preferred. An alternative would be with fluconazole. And then the other really big part of induction is managing increased intracranial pressure if needed by frequent LPs or even a shunt potentially if it's really high. And then these are some of the papers. So this paper looked at randomized clinical trial published in the New England Journal about different combinations of antifungal medicines for treatment of cryptomeningitis. And so these look at all-cause mortality as the outcome, so a pretty solid outcome. And then they looked at, you can look at this figure C or panel C. Lowest mortality was seen in that amphotericin B plus flucytosine group. And they also looked at 1 versus 2 weeks. Higher mortality was in that amphotericin B plus fluconazole for 1 week. And you can see in here, they just collapsed the groups that got amphofluconazole for 1 or 2 weeks versus amphoflucytosine. And so amphoflucytosine actually had improved mortality and is the preferred treatment. There's also been randomized controlled trials in New England Journal for adjunctive dexamethasone in HIV-associated cryptomeningitis, and people actually did worse with dexamethasone, and so survival was lower. And so we do not routinely give cryptomeningitis or give steroids for cryptomeningitis. There's also a couple years ago, more recently, there was a trial published looking at single-dose liposomal amphotericin B treatment for cryptomeningitis. So it was a single dose followed by oral flucytosine and fluconazole versus a control regimen, which is not exactly what we do here. It's amphotericin deoxycholate and flucytosine for 7 days followed by fluconazole. It actually showed that death from any cause was lower in the experimental regimen, that single dose. But again, the comparison group was not what we typically do here. And here in the US, we typically are a high resource setting. And so we typically monitor people on our standard regimen because sometimes people do get worse after starting treatment and you need control of that intracranial pressure, which generally we like to monitor that inpatient until they're improving. So a repeat lumbar puncture is performed on as George nears 2 weeks of antifungal therapy. He's feeling much better. His headache's nearly resolved. His opening pressure is 20, white count 6. His cryptoantigen is positive in the CSF and his culture is negative. So what's the next step in your management?
Switch D. switch to fluconazole daily, 800.
Yeah. And why the high dose instead of the low dose?
Just to be sure that it doesn't recur. Not so.
I mean, it's a part of the protocol. Are you worried about the crypto antigen that's still positive in the CSF?
Yes.
No?
No. No.
Yeah, right. No. Yeah. So you got the right answer. At this point, you're ready to switch from the induction therapy to consolidation therapy for cryptomeningitis. And so you transition when they're clinically improved, the CSF culture is negative, and generally you want 2+ weeks of that induction regimen. Monitoring serial cryptoantigens isn't going to help. They don't reliably like downtrend with treatment, and especially not in that 2-week setting. So they can be sort of, if you try to follow them, you're not going to really know what you're doing. So we do want a negative CSF culture before we consolidate. And the consolidation therapy, as you mentioned, is the high dose of fluconazole. And you do that for generally 8 or more weeks before you eventually transition to maintenance therapy with the lower dose of fluconazole for at least 12 months. And for many of these infections, especially these fungal infections, there are very specific guidance on when you can actually stop like the antifungal altogether. For crypto, it's when your CD4 is above 100, you're virally suppressed, you don't have symptoms, and you've gotten at least a year of therapy. These are things that I do not memorize and I look up, but I included them here in case anyone was interested and in case you asked, because I, again, don't remember them. Okay, so the other big question that comes up, and again, we've had this in multiple patients on our service, is when should this patient with cryptococcal meningitis start antiretroviral therapy? Celia, I believe I heard your team discussing this.
Yeah, it should be C. So you want to start right away because it's transvirus.
Exactly. This is one of those exceptions to the graphs we looked at earlier where we want to start ART within a couple weeks. For cryptococcal meningitis, we want to wait 4 to 6 weeks after starting crypto treatment. And again, this is another like randomized control trial that looked at this. They took people with cryptomeningitis and either started early ART, so within 1 to 2 weeks of diagnosis, sort of that same time frame we were looking at when we were talking about PJP, or they looked at people who had deferred treatment, like 5 to 6 weeks after diagnosis. And you can see that the cumulative probability of survival was higher in people who were deferred. So more people with early ART died. That was both clinically and statistically significant, I would say. And that this was especially pronounced when they stratified it by the people's CSF white cell count. So in people who started with a super low white cell count, less than 5, those were the ones who really saw more harm with the early ART. They were just so immunosuppressed to start. And then, so say George starts ART 4 weeks after initiating cryptomeningitis. He is taking fluconazole 100% adherence, and a month later he gets a headache again. His CD4 is now 150. Repeat LP shows an elevated opening pressure with negative CSF cultures. So what do you do next? And so what's going on with him?
Is he getting immune reconstitution inflammatory syndrome?
Yeah, that's what he's sort of in the right time frame, a month after starting antiretroviral therapy, to have IRIS, or immune reconstitution inflammatory syndrome. So how would we manage IRIS in the setting of cryptomeningitis?
Would it be B?
Yeah, anyone else have thoughts? Would anyone stop ART? Okay, close. Because his CSF culture is negative, in this case, you try to manage his IRIS by continuing the ART and fluconazole, and then often you'll try to add steroids or NSAIDs to reduce the intracranial pressure. You don't have to restart induction if the culture is negative. So iris, a quick review of iris. It happens more commonly in people who are more immunosuppressed to start with. So people with low CD4 counts and high viral loads are the ones we most worry about iris in. And there are two types. There's paradoxical, where you have worsening of a known infection when you start ART, and that would be like the patient we had just now. Or you can have unmasking iris, where you have the immune system coming back exposes an infection that you otherwise didn't know. The most common opportunistic infections where we see iris are MAC, cryptomeningitis, TB, PML, and CMV retinitis. And so in many cases, generally you try to continue antiretroviral therapy. You make sure you have the right diagnosis, especially if they're having new or different symptoms. You want to make sure you didn't miss something that you can treat. And then in cases where symptoms are more severe, you sometimes consider NSAIDs or steroids to help manage the symptoms, to carry them through until they get through the iris. And this is the table we looked at, or the figure we looked at earlier, where for most opportunistic infections, early ART improves outcomes. And some of the big exceptions are tuberculosis and cryptomeningitis. You want to wait longer after you start treatment. Again, both of those are CNS infections in a closed space. Other comments is just for infections where we don't have any sort of directed therapy, things like PML or crypto, we generally want to start ART immediately because that's their only chance of not getting worse. Okay. So now we're going to move on to another common presenting clinical syndrome in people with HIV, odynophagia. Someone read Sheila's case, please.
So Sheila is a 48-year-old woman with HIV, not on ART. CD4 is 65, viral load is 510,000. She presents to clinic to discuss ART initiation. Reports retrostomal chest pain with swallowing and altered taste sensation over the past 1 to 2 weeks. Oral thrush is present on exam. What is the next step in management? I would go with A.
A?
Yeah.
Okay. You're not going to do any workup. You're just going to start treatment.
Retrostomal chest pain.
Good call.
Yeah.
So,
Doubt myself for a second.
I know. I was sort of lonely in this office presenting by myself. So for presumed esophageal candidiasis, you can treat empirically. If they aren't getting better, that's when you would move on to more advanced workup, with usually with an EGD. Or in people with recurrent, you may worry about, do they have resistant candidiasis? But, on a first episode, that's pretty unlikely to be the case. And you can safely start antiretroviral therapy in someone with esophageal candidiasis. And so odynophagia and HIV, and it sort of varies on what the cause might be based on CD4 count. If it's between 100 and 200, then you might have some oral thrush. Usually you don't have so much esophageal involvement. When CD4 counts below 100, then you start to see esophageal candidiasis, and you start to think about other things too, like could it be HSV? Could they have GI Kaposi? And as your CD4 count gets lower, less than 50, then you worry about things like CMV and aphthous ulcers. We actually have someone in the MICU right now with CMV esophagitis and CMV retinitis. So she follows this trend. She sort of has CMV everywhere. And then remember that, as always, our people with HIV are still people, and all the other things that can cause odynophagia in anyone could also cause a problem in them. So Sheila's feeling better a few days after you started fluconazole and antiretroviral therapy. She plans to complete the course, and she tells you that she never wants to experience that symptom again, and she asks how she can prevent recurrent infection. And so what do you recommend for secondary prophylaxis?
D.
Yeah, good job. So for esophageal candidiasis, we don't do prolonged courses of secondary prophylaxis or suppressive therapy or whatever you want to call it, until CD4 count recovers. Usually if people are having recurrent episodes of candidiasis, we treat them when they come up, It's generally our acute therapy is effective. The mortality from this condition is generally low. And if you do keep people on for long term, there is an increased risk of resistance, as you guys all know. So now we're gonna talk about a couple more. We really went fungal heavy. I changed the order around so we focused on different ones than last time, but a lot of fungal. Okay, so Joe's case. So Joe's a 36-year-old man with HIV who's not in care. He's admitted to the ICU with cough, dyspnea, fever, and hypotension. He also has a 2-month history of weight loss and night sweats. His CD4 count is 85. He recently moved to Florida from Indiana. Initial workup is notable for a positive urine histoantigen. So what's the most appropriate antifungal therapy for disseminated histo? A. Have you guys seen a disseminated histo case?
One.
No.
And in this case, the question tells you what it is, but what about his history would make you think to send that urine histoantigen?
It's Indiana.
He's in the Ohio River Valley.
Mm-hmm. Mm-hmm.
Hypotension, I think that you can get like adrenal gland.
Mm-hmm.
You're right. Infiltration.
Yeah.
It sounds like tuberculosis too.
Mm-hmm. Yes. In this case, they ruled them out for tuberculosis. No. Perfect. And so histoplasmosis, you guys got the geographic area. You guys picked up on Indiana right away. But, we think about that area, but it is like what they call mildly endemic, like outside of that narrow, like Ohio River Valley area. And so, if they've been anywhere potentially, you want to consider this, especially if someone's presenting like with disseminated disease, which can include sepsis and shock. A lot of our infections don't quite cause that shocky of a picture in people with HIV. Pulmonary disease, you can have isolated pulmonary disease with respiratory symptoms, and there's different things you can find on CAT scan. It can cause a meningitis as well. For people with disseminated histo, this looks at the sensitivity of different diagnostic methods. So antigen detection from urine or blood is generally your most sensitive. And then culture, serology, and I can't see what the last one says. It's showing it, or it's my little team screen is covering it up, fungal stain. An antigen usually returns pretty quickly too, at least here at TGH. And so that can be a really helpful test to send early on. And as you guys already guessed, for treatment, if you have moderately severe or severe disseminated histo, you're going to start liposomal amphotericin B. You're going to do it sort of like crypto for 2 weeks and then make sure they're improving. And then eventually you'll transition to maintenance therapy with oral itraconazole is the one recommended for 12 months. If it's less severe disease, you may not need the 2 weeks of amphisome to start. And then as for crypto, there's some in people who've had a histo infection, you put them on suppressive therapy, and there's criteria, but in short, they need at least 1 year of therapy. So it's always helpful to tell people up front that they're going to be on a lot more pills to start with, and over time, as they get better, we can hopefully streamline some of their medications. I try to tell people with HIV that so they don't think they're committing to lifelong so many pills. Okay. All right. Could someone read this one?
I can read it. A 35-year-old cisgender woman from Arizona with chronic HIV and a recent CD4 count of 133 cells presents with fever, cough, dyspnea, lymphadenopathy, and skin lesions. After an extensive evaluation, she's diagnosed with pulmonary coccidioidomycosis and disseminated disease without meningitis. Which one of the following is recommended for treatment of disseminated coccidia without meningitis? I'm gonna still say liposomal amphotericin B.
And you would be correct. So sort of like we looked at for histo, for cocci, endemic area for Cocci is more of the Southwest, as you guys know. You can make the diagnosis the same way you can diagnose histo, same sort of tests. And then you can consider prophylaxis when people are in an endemic area and when they meet certain criteria in terms of their CD4 and their Cocci antibody status. A little less relevant for us here in Florida, but I know I had a co-fellow who moved out west and then was shocked by all the Cocci she was seeing. And as we mentioned, if you have severe pulmonary and extrapulmonary, you do amphotericin until improving, and then you switch to an azole. And I'm not going to go over again the criteria for discontinuing therapy. Okay, so we have a few more minutes, so let's move on to this case of Marco. Could someone read this?
Marco is a 45-year-old man with 2 weeks of abdominal pain and cramping with large volume, watery, non-bloody diarrhea. He presents to ER where HIV antigen antibody is positive with a CD4 count of 42. You were consulted for evaluation. Modified acid fast stool demonstrates organisms 4 to 6 micrometers in diameter. Is GI PCR is positive for Cryptosporidium, which of the following will be the most helpful in improving symptoms, which is D.
Yeah, I think I even mentioned it earlier. I moved things out of order. But right, so if you look it up, this is cryptosporidiosis, typically occurs when CD4 is less than 100. And there are options for antimicrobial therapy, nitazoxanide, promomycin. So you'll see these recommendations, but without ART, we often see these patients just come back in again and again. And so you really do your best to get that person on antiretroviral therapy. In severe disease, you may use those therapies as well, but the goal is antiretroviral therapy. And just a quick note about transmission, it can occur in contaminated water supplies despite chlorine. And it can also be transmitted from among men who have sex with men. And then this slide is just sort of some causes of diarrhea in people with HIV and possible hints to the infection. So like cryptosporidiosis can occur, usually it's less than 100, but it can occur at a little bit higher CD4 count than we see things like MAC or CMV colitis typically. Whether you have bloody diarrhea, if you have fever and weight loss, sexual practices, can all hint to different causes. And then the bottom ones are sort of recent antibiotics causing C. diff or homelessness with Hep A, apply to more than just people living with HIV, but are still things to think about. Let's do Chris's case.
Chris is a 29-year-old man with HIV not on ART. CD412 load is 1 million. He presents with diarrhea, fevers, night sweats for several weeks. CT showed an para-aortic and RP lymphadenopathy, 102.5 Fahrenheit. Crypto on the GI panel, cryptosporidiosis. What is the next step in management? Nitazoxanide, ART, AFB, blood cultures, or stool AFB?
AFB blood cultures.
And why do you say that? What are you concerned about?
No.
MAC or MAC?
Yeah.
Because
yeah. What were you going to say, John?
the GI panel won't show that.
Exactly. Yeah, GI panel won't diagnose MAC or CMV, which are two big causes of HIV-associated diarrhea. So you'll need AFB blood cultures or a biopsy for CMV. But I think the point of this question is also to remember that people who are so severely immunocompromised, especially when your CD4 count is like under 50, they can have multiple and usually do have multiple infections at once. So just because you have a GI panel that has one organism, if that can't explain the rest of your picture, like Cryptosporidia wouldn't explain the lymphadenopathy, and probably not those fevers and night sweats this patient's been having. So you have to sort of make sure you're addressing all the symptoms and working up all of it. So you guys are right. Then this one, you can't just hang your hat on that. You got to go further with more workup. And this one shows the blue bars is 6 months incidence. The gold bars are 12-month incidence of MAC related to baseline CD4 count. And the big thing is just, again, like when your CD4 count's less than 10, it's like a third of people are getting MAC or more in a year. And really anyone sort of below that CD4 count of 40 or 50, there's a pretty high prevalence of MAC in that population. And in people who have disseminated MAC infection, fatigue is the most common, followed by fever, diarrhea, night sweats, abdominal pain. But you can see that none of them, you know, people often won't have all of those symptoms. So you have to have a really high level of suspicion for it and send the test. And so in this case, you sent the test, the AFB blood cultures are positive, and Mycobacterium avianum intracellular is detected, but you had such high suspicion that you had already started treatment earlier in the course, which is typical, right? Like we're usually not going to wait 2 weeks if we're pretty sure based on imaging and presentation that it's this. So what's the recommended preferred treatment for disseminated MAC infection and HIV?
Rifabutin and Thiamidol. But he is on.
What do you guys typically give people?
C, no? C, right?
3 of them.
Yeah,
Isn't it typically a 3-drug regimen?
Yeah.
It's like one of the newer azithromycins and a thiambutal and a rifamycin.
Yeah, usually we often do a 3-drug regimen, but according to the guidelines, the preferred treatment is actually 2 drugs.
Probably
Does anyone know which 2?
A.
Yeah, good guess. So per the guidelines, the preferred therapy is at least 2 drugs, and usually we do a zithro with thiambutal. And they say you can consider as alternative therapy adding a 3rd drug. And you're wanting to add that 3rd drug if they have advanced immunosuppression, high mycobacterial load, or they're not on effective ART. This is, I mean, most of our people with HIV who we're diagnosing with disseminated MAC fit this criteria, right? Otherwise, they probably wouldn't have disseminated MAC. So you guys are right. We typically do the 3-drug regimen to start. You may see people add rifabutin, or you may see people add amikacin. There are different options. And then with MAC, when do you start ART?
You can start ART at the same time.
At the same time?
Oh, sorry. Yeah, you can, per guidelines, you can start it at the same time. I'm not saying you actually need to start it the same day, but you can get IRIS to MAC with antiretroviral therapy, meaning like you'll see fevers and symptoms, fatigue. Generally, that's associated with low mortality and a favorable long-term prognosis. If they're having a lot of symptoms, again, for an IRIS picture, you can treat with NSAIDs or steroids to sort of calm down that inflammatory response, but you'd usually keep both of them on.
What is the criteria to do the 3rd?
Advanced immunosuppression. Okay. Which our
yeah,
patients
I see.
use.
That's what she was saying. Okay.
Thanks, Lauren.
I'm sorry. I know I was unmuted. Oh my god, I'm just like trying to write notes and I'm behind.
No, that's fine. It's like advanced immunosuppression or high viral load or high bacterial burden, which is, I feel like pretty much everyone we see with HIV and MAC has like a CD4 count of 5 or something.
Makes sense.
So
sorry.
yeah, no, you're fine. And one thing that's important to know about the clinical course for MAC is that the fever doesn't improve like the day you start therapy. Fevers usually improve over a couple weeks. And then if you were to repeat blood cultures a couple weeks later, usually you can clear it then. Typically, we don't necessarily repeat blood cultures in a couple weeks unless there's ongoing symptoms. But the fever curve is important. So like you clearly want to work up any potential causes of fever, but you could explain a fever that's going on for a few days after you've started therapy. I think this might be our last question we're going to do today. So Chris follows up a year later, and he's reports excellent adherence to his ART and MAC treatment. He's feeling great without fevers or night sweats or lymphadenopathy. And he's hoping to decrease his pill burden and asks how long he needs to be on the MAC treatment. So now his CD4 count is 170. His viral load is suppressed. 6 months ago, his CD4 count was 120 and he was still virally suppressed. And so what do you recommend for him?
D.
Oh. Yeah, so this one's a little bit different. So
Oh no.
I know, I tricked you guys. I told you I look these things up all the time, generally when you can stop these long regimens. So chronic maintenance therapy, you keep him on the same regimen as you did for initial. If you start with 3 drugs and he's having side effects, you could probably safely drop down to 2 drugs over time. And you stop the chronic maintenance therapy when they've gotten at least a year of therapy, which he has. They have no signs or symptoms of MAC, and their CD4 count is greater than 100 for 6 months with ART. So this is where it's just important. If you're in clinic and you're getting a patient who was, admitted 6 months ago for a variety of opportunistic infections and they're still on, suppressive therapy or chronic maintenance therapy for these, you're probably going to have to look up the criteria for when they can safely stop each of those. And it differs whether it's 6 months, 12 months, CD4 of 100, 200, or what. Okay, we're going to skip those. Last year we did those cases about toxo. This is a bit of a whirlwind. I hope the case-based approach sort of helps review some of these because sometimes you see the cases a bit sporadically and sometimes they come in waves here at Tampa General. So do you guys have any questions about anything we covered today?